Welcome to Medscape. I'm Dr. Andrew Wilner, reporting virtually from the 2022 American Epilepsy Society meeting in Nashville, Tennessee. Today, I have the pleasure of speaking with Dr. Joseph Servin, professor of neurology at the Mayo Clinic, Jacksonville, Florida. Welcome, Dr. Servin.
Dr. Wilner, it's always a pleasure to be with you.
Dr. Servin, you just did a very interesting presentation at this year's Wake Forest Symposium on social determinants of health and epilepsy. Can you give us a brief synopsis? What's that all about?
You bet. So one of the things that I've been kind of focused on, actually me and a team, is to try to figure out, first and foremost, to start out with a very simple question, which is, I started out with the concept of like trying to address when people are always talking about epilepsy surgery patients, a very different topic. And where are they? There's always this concern that we're not reaching them, we're not doing enough, we're not getting enough throughput, if you will, to get people to curative therapies. And one of the things that started by just a very wayside conversation with someone completely not involved in the field of epilepsy was, I said, I suspect that this is really all about social determinants of health. And so, as someone who was not an expert in that topic, it was kind of a genesis of a larger project to which we worked on for a few years and published both in a paper form and a book form, this whole idea of social determinants of health and how it impacts epilepsy. And so this symposium, we kind of like try to summarize some of the bigger key findings. What are they? How does it imply? And what did we find for one particular population of individuals with epilepsy? And that was kind of the what we were trying to do at the presentation, is to point those things out.
Now, I remember reading something about this. I think you looked at a population in Arizona. I think coincidentally, you used to be the chairman of neurology there at the Mayo Clinic. It might have had something to do with that selection of that population. So tell us what you found.
So it was interesting. So one of the things that we wanted to assess is, like, first of all, social determinants of health is looking at just those key demographics that we often quickly overlook the moment that someone seeks care. I always think of, like, when I open up the electronic medical record, there's this page which tells you address, zip code, insurance, ethnicity, gender, faith, education, salary in some weird cases. How does that play into this? And so what we did is that we found that that perhaps if we examine that relationship, we'd see how does it tie in to epilepsy treatment gaps. It so happened when I was in Arizona, one of the Arizona Medicaid, which is they call it access there, which is the safety net if you do not have insurance at a federal level or commercial level. That's what Arizona will do. And it's actually considered a relatively good state Medicaid program. It expanded under the time of Obamacare. And the database for Arizona Medicaid is housed at Arizona State University. It's what's interesting. There's 50 states, there's 50 laboratories that look at this, and each state has its own Medicaid program. So we were able to access this database that really you have to, it sits quietly in this place at Arizona State, and to examine it for patients with epilepsy and try to understand how those demographics of social determinants of health impacts the care of epilepsy. So out of that's where we kind of started this whole project to try to figure that out and really try to use that information to kind of give us a sample of what one state, a large state, an expanding state, what does that look like? And then hopefully use that as a crux to compare it to multiple other locations and states as well.
Now, all of those patients in that database had Arizona Medicaid, right? Is that correct?
That's
So that's already a social determinant of health right there. Did you, when you probe deeper, what were the other social determinants that really mattered?
So the ones that mattered, or things that I think will not surprise people, but it's important that it kind of comes in there. Number one is whether you had a job. That if you did not have a job, you were much less likely to be treated with a medication with a diagnosis of epilepsy. That is, it's coded. You've been in the state for more than 2 years. I mean, we had all these parameters to make sure we got that right. If you're homeless, if you were widowed, you were much less likely to be managed, and that is get medication treatment for epilepsy. If you were of a certain ethnic group, Native Americans in particular, were far less likely than Caucasians and other groups to receive epilepsy therapy, to either have it filled or started or whatever reason. That was by a significant factor compared to others. So even ethnicity had an important role. Where you sought care also had a big role. If the person was diagnosed or managed or treated in a hospital setting, they were much more likely to do better. So actually, emergency rooms, people were started on treatment. But if they did not go to an emergency room, if they did not do it in a hospital and went to a non-traditional medical setting, a clinic, a free clinic, something along those, in that mindset, you are much less likely to be started on medication or to be treated for your epilepsy. The other thing, age had a role. The older you got, the less likely you were to be placed on medications, curiously, even with the diagnosis. And that was kind of the big chunk of it. So there were a lot of these very hyper-specific demographic pieces that determine what was going to happen. And let me kind of point back a little bit further. What we found was that the average treatment delay was close to between, like, from the time that you got a diagnosis, that you definitely, it fit, you were coded as such, it was anywhere from, excuse me, from 3 to 6 months. 3 to 6 months that the person's treatment delay occurred, that they didn't receive any treatment, no drug, nothing. And this is important because Arizona Medicaid tracks whether they fill your prescription too. So you know whether that even was filled at a pharmacy. So a lot of different factors are important. And it got back to my original question, which was, that epilepsy surgery. I think that person was right, at least for this group, because what it tells you is that if failure of 2 medications is how you get it down a road to go down the road of being marked as drug resistant, here no one even starts the journey, is what you find, because there's such a delay or non-treatment, and these other parameters are impacting them. You never get to a place of being labeled as drug resistant because you never started down the road.
I think what's interesting is that your study controlled for insurance, because they all had the same insurance. So it wasn't a question of, well, I have insurance, he doesn't have insurance. The study controlled for that because they were all in the Medicaid program. So presumably they all had similar access, but at least in terms of ability to pay. And yet there were these very important differences that really prevented them from getting the care that they need. So was the bottom line that you figured out how to fix this problem?
Oh, how we wish. I will say that we certainly know a couple of things. Number one is that the sad thing about social determinants of health, on one, it is the fact that that's not what physicians control or health providers control. Those are upstream factors. That sits in the land of policy, in legislation and advocacy. But it is important to know this because I will tell you, just over the course of the past several years in practice, I've noticed how the questions from patients have shifted. It used to be that, when I would see someone and start a medication, great, I'm so glad there's a choice, so on and so forth. Let's talk about side effects. How well does it work? What I notice now is most often with those questions, the question right next to all of them, how much is this going to cost me? Is my copay just too much? And that's what I'm finding, is that now, whether we want to or not, we're now going to, physicians, health providers, we're almost in a role that we have to deal with the social determinants of health, which forces us to be almost more policy minded. I don't want to say political, but policy minded, much more than we ever used to be. And that is how we get there. So the solution is not hard in understanding what it is. The solution's hard in trying to make sure that it can be implemented.
I know the American Academy of Neurology on its podcast has begun talking about the financial toxicity of our treatments and how it's just not enough. I think they agree with you. It's not enough just to write the prescription without being aware of the copay and whether the patient's even going to be able to fill that, or not.
I think it's just life has changed in that way. I'm always amazed when I do get the phone call back, and I don't know what a patient's copay is going to be based on what I prescribe, because that's often determined by what their insurance coverage is, how good it is, and so the economics of of what is you think it might cost, and then this is what it actually costs. I mean, that's still a mystery. So half the time, I'm stunned when they call me, Dr. Silverman, that med, and it's not like a brand new spanking medication. It could be just something that's been out for a while, but there aren't a lot of generics on it, is costing us $1,100 a month. Well, $1,100 a month is, that's getting into mortgage land and car payments, or 2 car payments. It's significant. And then you start seeing why things aren't moving the needle overall. I think that's just part of the picture.
Well, because the goal for all of us is that the patient should get the care and treatment that they need.
Absolutely.
Well, Dr. Servan, I want to thank you very much for telling us about your presentation at the American Epilepsy Society this year. Thanks for joining us on Medscape.
It is always a pleasure to join you, Dr. Wilner. Always a pleasure.